¿Qué tal? Buenas noches. Soy el doctor Ismael Domínguez Rosado, cirujano hepatopancreatobiliar del Instituto Nacional de Nutrición. Es para mí un gran honor coordinar esta mesa redonda con líderes de opinión sobre un tema altamente controversial y apasionante, como son las resecciones arteriales en cáncer de páncreas. Y les agradezco al doctor Truti, al doctor Franzen, al doctor Kim y al doctor Helton participar en nuestro congreso en esta ocasión en formato virtual. Quiero recordarles a los asistentes al Congreso que pueden ustedes poner preguntas en la pantalla, en la parte inferior de la pantalla hay un espacio donde ustedes pueden poner preguntas y nosotros las transmitiremos aquí a los doctores y gracias al excelente sistema de traducción podremos tener respuestas de los mismos. Bien, pues hemos visto las posturas a favor y en contra, tanto del doctor Truti como del doctor Franzen, y quisiera preguntarle al doctor Truti cómo es el proceso de cumplir esta curva de aprendizaje en las resecciones arteriales. Evidentemente, estos pacientes se tienen que tratar en centros de alto volumen, pero por ejemplo en un país como el nuestro, donde nosotros somos un centro de alto volumen, pero no tenemos experiencia en resecciones arteriales, ¿cómo deben de iniciarse estos casos? ¿Qué pacientes hay que hacer? ¿Qué procedimientos son los más seguros al inicio de esta curva de aprendizaje?
So that's an excellent question. You know, I didn't come on faculty planning to take this on as a practice. You know, I was told to either start doing laparoscopic Whipples or figure something else out to do, and I didn't want to do lap Whipples, so I figured I'd take on a niche. You know, I was always told if you want to be successful, you know, do something that someone else is not doing, do something else that you think someone's doing wrong, or do something no one else wants to do. You know, and so, you know, at that time, no one was really doing much of this. And I thought if you could at least approach this logically and safely and then start slow, I think that's the key thing. You mentioned a couple of things. Yes, it's about, you know, patient selection is critical. Making sure these patients have a good biology. Now, biology is not just, it's not a static thing, it's a dynamic thing. Can we, you know, we think we could change the biology by potentially having better effective treatments. And then finally, the key thing is you have to have a champion, someone who wants to take this on. You can't dabble in this. You have to have the infrastructure available at your institution. You know, I couldn't do this without the help of my GI colleagues, you know, my IR colleagues, the ICU team, you know, and the rest of the, you know, people treating these patients. Because, you know, I push the envelope surgically, and therefore I'm asking IR and GI to do things they've never done before. And then we sort of co-evolve, and then we get a little bit more comfortable. And yeah, you do well for a while, you have a bad outcome, you back off a little bit. Okay, and you say, what did we do wrong? How can we improve it? And so the key thing is my practice today is very different than it was 6 months ago, very different than it was a year ago. And I hope 6 months from now, I'm doing things differently too, because we're learning. And so that's the key thing. You know, my first artery was a hepatic artery, and then the second one I did was a celiac SMA combined. It was a patient who's been treated, you know, for 30 months of chemotherapy. His tumor was all completely calcified and all along, just along the vessels. And I said to myself, boy, this is really locally dominant. It's probably dead. You know, can we come up with an operation to take it out? So it's not, you don't just jump in and start doing these. It's a slow process.
Muchas gracias, doctor Truti. Doctor Franzen, ¿existe algún estudio de calidad de vida? ¿Sabemos en términos de calidad de vida cómo le va a los pacientes con resecciones arteriales? ¿Es equivalente a un paciente que recibe únicamente quimioterapia o es equivalente la calidad de vida a un paciente que tiene un Whipple sin resección arterial?
Muy buena pregunta. Primero me gustaría agregar algo a la pregunta que le hiciste al doctor Truti, y eso es que esta es una de las operaciones que no solo requiere de una gran experiencia quirúrgica, sino que también es muy importante tener ciertas cosas físicas disponibles, como es un gran equipo de radiología intervencionista, por ejemplo, tener la posibilidad de operar a un paciente en cuestión de media hora si hay un sangrado en la mitad de la noche, tienes que tener un equipo de gastroenterólogos excelente, por supuesto tener radiación preoperatoria y neoadyuvancia. Es decir, hay que cumplir con ciertos requisitos para siquiera empezar a pensar en hacer estos casos. Ahora, para contestar tu pregunta, yo no conozco ningún estudio de calidad de vida sobre que compare pacientes con un Whipple normal y un Whipple con resección arterial. Sin embargo, si consideramos las cirugías más radicales, que incluyen, como dijo el doctor Truti, una gastrectomía total y una pancreatectomía total, por ejemplo, pues yo asumo, hasta no encontrar información que pruebe lo contrario, que esos pacientes tendrán peor calidad de vida, o por lo menos se tendrá que hacer un esfuerzo mucho más grande para que logren una calidad de vida similar.
Muchas gracias, doctor Franzen. Doctor Truti, adelante.
Can I jump in quick?
Claro, adelante.
Yeah, so, with our experience, this is something we're looking at, keenly. Now, just because a patient is a candidate anatomically, we could reconstruct them and they responded, doesn't mean that, we offer them. We're not here to persuade someone to get this operation. They have to kind of ask us for it, and we have to make sure that, that they qualify. We've been following these people for a while now. Obviously, we wouldn't continue doing it if patients were miserable. Some of the things that you think would be a problem are not. The total pancreatectomies, the brittle diabetes, that's gone. That's not an issue anymore. People have these glucometers, they have insulin pumps. Their A1Cs are better than mine currently. That has never been a long-term issue for them. Primarily, it's been diarrhea. That's the one thing I tell them. You're going to have diarrhea. There is a small segment, maybe 10% of people that don't have it, shockingly. A majority do. It can be pretty significant, particularly within the first 3 to 6 months. It does get better, so you have to counsel these patients. And I tell them, I see these people about 10 times prior to their ultimate operation from the beginning to the end. And I keep reminding them, and they always say, boy, you didn't tell me the diarrhea would be this bad. And I told you 20 times, so you just got to get them through it. It's usually about the 4 to 6 week period post-op, once you get past the rough patch and all the life-threatening things are away. The climax of the operation is over, and now they're still not feeling good. They can get depressed, they're questioning, should they have gone through with this? And that way you have to sort of be a psychiatrist, with the patients and make sure that, we did this for the long term, not the short term. But ultimately, surprisingly, if you did a short-term quality of life, it would definitely be significantly detrimental. Longer term, I do think it gets back, not quite to normal, but somewhat the new normal. And so, again, every patient has a different goal, quantity of life versus quality of life. The 75-year-old patient has probably a different ratio than the 39-year-old mom with 2 babies at home, who'll let you do anything to her to give her another week with her children. So you have to understand where the patient's coming from and what you can really offer.
Gracias, doctor Tutti. Doctor Helton, alguna vez el doctor Cameron comentaba en un American Surgical respecto a la terapia adyuvante.
Ismail, I apologize, but I am not getting any translation coming through to me. I clicked on the English, but I'm not hearing any translator.
¿Podríamos ayudarle al doctor Helton en lo que continuamos con el debate? Mientras continuaré preguntándole al doctor Kim. Doctor Kim, ¿alguna vez el doctor Cameron en una American Surgical respecto a la quimioterapia en adyuvante comentaba, se cuestionaba si estamos realmente únicamente operando más pacientes con la quimioterapia en adyuvante o realmente los pacientes están viviendo más porque les demos quimioterapia en adyuvante? Y en analogía con las resecciones arteriales, ¿realmente al hacer resecciones arteriales estamos únicamente operando más pacientes o estamos realmente logrando que vivan más tiempo y que tengan una mejor calidad de vida?
Good question. I think the philosophy of the treatment of this patients shouldn't be focused on surgery itself. As Dr. Trudy mentioned, it's not. I know the title of the session is stated as arterial resection of the pancreas cancer, but really it should be a surgical therapy in the setting of a pancreas cancer treatment. I think we all know that pancreas cancer is a systemic cancer and that the best survival is achieved by surgery plus chemotherapy. I think the operation itself, I know that it's a big operation, and this really shouldn't be called a Whipple or distal plus artery. I think it should be named something completely different. But you're absolutely correct. I think we are selecting patients. And then second of all, I think the neoadjuvant chemotherapy that we have now with FOLFIRINOX and Gem/Abraxane have certainly helped us to operate on more patients.
Gracias, doctor Kim. Doctor Truti, uno de los factores que usted menciona de más importancia para seleccionar a los pacientes que se benefician de una resección arterial es la duración de la quimioterapia neoadyuvante. Sin embargo, sabemos que el FOLFIRINOX puede ser agresivo y con tolerancia difícil para ciertos pacientes. ¿Qué hacen en la Clínica Mayo cuando un paciente no tolera FOLFIRINOX?
So, we have a paper coming out in the practice we've had for several years now, the concept of chemotherapeutic switch. So, you start with your first line, typically, here in Rochester and most places, if they're otherwise fit, we start with FOLFIRINOX. We reassess typically every, 2 months. If they're not having objective responses or they're having intolerance or toxicities, then we switch to second line, which would be Gem/Abraxane. Now, that's something a lot of the oncologists thought was, heresy. If you don't respond to one chemo, you're not going to respond to anything. And that's actually false. We found we've been able to salvage about 60% of our patients with a second-line therapy, going in either direction. But the key thing is, it's not just neoadjuvant in general. Why did it take neoadjuvant so long is because we, initially started with neoadjuvant Gem, which has a 7% response rate. And we said, boy, it's not beneficial. It's not that neoadjuvant isn't beneficial, it's just neoadjuvant Gem isn't beneficial. You could give someone 12 months of neoadjuvant hamburgers. They're not going to do any better. You have to give them something that's actually effective. And so if we're giving someone therapy thinking we're going to change their outcome versus an upfront resection, we have to prove it's doing something. And I think that's where the field is going now. It's not neoadjuvant or not, it's how do we assess that? Because traditional radiologic monitoring, is not good. Biochemical response is not adequate in about 40% of patients. We use PET. I'm hoping to get some new technology to be able to figure that out.
Gracias, doctor Tuti. Doctor Franzen, ¿qué opinión tiene usted de la radiación neoadyuvante? ¿Realmente la radiación tiene algún impacto en sobrevida o en facilitar la resección en cánceres localmente avanzados, o no hay ninguna diferencia entre dar o no dar quimiorradiación neoadyuvante?
Es controversial, pero personalmente yo sí creo en la neoadyuvancia con radiación. Yo creo que el propósito de dar radiación preoperatoria es incrementar tu oportunidad de márgenes R0 y habiendo operado a muchos pacientes que han tenido radiación, no creo que dificulta la operación. Si operas en cierta ventana, alrededor de entre 4 y 8 semanas, incluso se ha visto que disminuye la fístula pancreática porque endurece el páncreas. Entonces, yo en lo personal sí doy radiación neoadyuvante, pero no hago resecciones arteriales comúnmente, y sin duda esto aumenta el riesgo de dehiscencia de las arterias, etc. Entonces, la combinación de una resección arterial y radiación es controversial, y por eso hay otros grupos que cuando hacen resecciones arteriales prefieren no dar radiación, como el doctor Del Chiaro. Pero yo sí creo en el aumento de resecciones R0 con la radiación preoperatoria.
And I think that's, Dr. Franzen brought up a great point. You're not going to find a whole lot of level 1 evidence that preoperative chemoradiation has a direct survival benefit. It's its indirect effects on margin status and nodal status, which both of which we know with level 1 data that do have a direct effect on survival. I use radiation for multiple purposes. One is obviously the margin and the nodal treatment effect. Second, I use radiation because I want to see what happens when we stop the chemotherapy, when we take the brakes off a little bit. Those patients where we move them on to long course chemoradiation and we see the tumor marker go up or the tumor start progressing, that's a big timeout to me, meaning we haven't controlled the tumor. Those are the patients that are probably most likely to progress post-operatively. If they develop stable disease during that period of time, then that is a good marker that it's probably reasonably to go forth with the resection. And then finally, for whatever reason, sometimes we can't resect them. It's more advanced than our scans have anticipated. We at least give them a way to get some local control.
Gracias, doctor Trudy. No sé si el doctor Helton ya tiene la traducción.
No.
Okay, so I will ask you in English so you can also participate.
Sure.
I'm sorry because of this, Professor. I know that you guys at Virginia Mason have a different way to give neoadjuvant chemotherapy. So you guys give a longer period of time of chemotherapy. Is this right?
Yes. Let me just say that we agree 100% with what Dr. Trudy said and how they follow their patients. We are big believers in following the CA19-9 curve. And I think that's really critical because as Mark said, you can't predict ahead of time, but you're going to find some patients that are resistant. We follow patients closely, and if we don't see their CA19-9 go down quickly, we switch therapy. We either go from FOLFIRINOX to Gem/Abraxane, or if they've started on Gem/Abraxane and we see the same thing, we switch to FOLFIRINOX. And I'd say our results are almost the same as his. We'll see about a 40% salvage rate by just switching the initial therapy. So the key is following patients very closely. We typically will treat even our borderline resectable patients for 6 months. And our results are identical to what other people have reported, and that is if the CA19-9 goes back into the normal range, that's a very powerful predictor of that patient having a better long-term outcome. So we'll be more aggressive in them. In those patients that are locally advanced and have arterial involvement, we'll give the 6 months of systemic chemotherapy up front. And then if that tumor hasn't regressed off the vessels, we will then add chemo RT, just like Dr. Trudy does. And then, only then, would we reoperate on them, again, if their CA19-9 had a favorable response.
And that's the key thing, you know, for this, we have to, as surgeons, take a more active role in the management of these patients. You know, if it's a more complex operation that they'll need, you can't just send them off to Med-Onc and say, okay, send them back when they're ready for surgery. That's not going to fly, because not to offend any oncologists on this call, oncologists have a different metric. They're looking for no metastasis. They could get 6 months of therapy and the tumor marker could triple. Hey, they haven't metastasized. We're doing well. That's doesn't work for what we're looking for. We have to have objective responses.
Doctor Trudy, en las resecciones de tronco celíaco clase 1, donde uno no tiene flujo retrógrado por la arteria gastroduodenal y uno tiene que hacer una resección más extensa, ¿cómo determina usted la necesidad de hacer una gastrectomía total o no? ¿Cómo evalúa la perfusión gástrica? ¿Utiliza un Doppler? ¿Utiliza verde-indocianina? ¿Cómo hace esta determinación?
So that's a good point, and this is something that in the sparse literature, there's also been a bit of a misnomer, because people keep confusing, you know, Applebee's gastric cancer operation. They think that all you need is a gastroduodenal artery. You're going to be plagued with a lot of postoperative gastric necrosis if you just rely on one vessel. You need perfusion of both the greater curvature as well as the lesser curvature. You have to have an intact and pretty dominant right gastric artery. Okay, you know, with the original Appleby, they took the stomach, so you didn't have to worry about it. People make a lot of analogies to the Ivor Lewis. You only need one blood vessel. They don't keep the whole stomach in an Ivor Lewis. They tubularize it. They take the lesser curve and the fundus, which are the ischemic portions, relying only on the GDA. So that's the key thing. You look at your scans, you make sure you don't damage that right gastric artery, and then we do obviously a lot of intra-op assessment. Doppler, we do indocyanine green with SPY, make sure we're having very good perfusion, particularly focusing on that lesser curve and that fundus, which typically the fundus is, you usually get the short gastrics only, and you're looking for cross circulation. If there's any question, we typically would rather favor taking the stomach or seeing what a supercharged, where you revascularize to see if that can improve. Because in our experience, those patients that develop gastric ischemia postoperatively, they have a 50% mortality. And having learned that from experience, that's not an operation you want to do, taking someone back and doing an emergency gastrectomy. It's a problem you want to completely avoid.
Gracias, doctor Trudy. Doctor Kim, el doctor Trudy mencionaba que la caída del C19-9, la quimio por lo menos 6 meses neoadyuvante y la respuesta patológica son algunos de los factores asociados de forma independiente a la sobrevida general prolongada en estos pacientes con resecciones arteriales. Pero, ¿realmente esto es causado por la resección arterial o es simplemente un surrogado de una biología tumoral pues menos agresiva y que permite que el cirujano pueda llegar hasta una resección arterial?
Yeah, good question. I think it's a indicator of lack of occult metastases as well as favorable tumor biology. I think if you look at the most recent adjuvant trial with FOLFIRINOX, they super selected patients after their resection, and they eliminated patients with high CA19-9 and also restaged them pretty quickly. And if you look at their survival curves, even their control arm with gemcitabine, they were able to achieve over 30 months of median survival, which is higher than the median survival observed in the SPAC-3 trial. So no, I think it's an indicator of biology and also occult metastases. I think I would certainly be very concerned if the CA19-9 doesn't come down with systemic therapy. Again, I think it's a systemic disease, or I think we're super selecting patients who have a specific phenotype of locally advanced without metastases.
Gracias, doctor Kim. Doctor Franzen, los márgenes, nosotros los cirujanos somos muy exhaustivos con tener márgenes negativos, pero en una enfermedad tan agresiva como el cáncer de páncreas, realmente tener márgenes R0 en el páncreas, márgenes R0 en los vasos, es lo que va a hacer que el paciente viva más, porque en realidad estos pacientes de lo que mueren es de enfermedad sistémica. ¿Qué tanto impacto realmente tienen los márgenes en la sobrevida general de estos enfermos?
Muy buena pregunta. Yo creo que en los únicos pacientes en donde repercuten los márgenes negativos es en pacientes que solo van a recurrir localmente. Y la mayoría, incluso en las publicaciones del doctor Truty recientemente, con resecciones arteriales, recurren sistémicamente. O si recurren de forma local, al mismo tiempo recurren de forma metastásica en el hígado, en el pulmón o en el peritoneo. Entonces, realmente en esos casos un margen negativo no va a ayudar. Pero sí hay casos que recurren solo localmente y esos para el cirujano son una pena. Y yo creo que esos son los que se pueden evitar con márgenes negativos.
Yeah, I'd like to comment a little bit about this. Bernardo is absolutely true. Regardless of what study you do and whatever neoadjuvant extensive, it's still systemic recurrence. That's number one. However, what you're seeing is the systemic recurrence percentage has come down and the local recurrence has gone up. Now, a local recurrence is not a benign thing. Okay, it's been proven it can be fatal in some cases. It certainly leads to a significant worse morbidity. And so, that's the only reason they called a surgeon, right, to deal with the local regional disease. And if we think we're really controlling systemic disease with chemotherapy, then our sloppy operation is going to be a lot more evident. You know, we used to get away with it 2 decades ago because everyone met it out very early. So you could do a terrible operation and you just blame the biology of the tumor. You know, now, hopefully, you know, with better systemic therapy, you know, our work is going to be a little bit more magnified. So we need to make sure that we're preventing that.
Ishmael, I'd like to ask Mark a question if I could.
Yeah, sure.
Mark, what is your opinion about doing total pancreatectomy, which you do a lot, I know, in patients having an arterial reconstruction? In the recent papers published by Del Chiaro, he comments that they always do a total pancreatectomy in order to avoid hemorrhage from arterial anastomosis in the case of a leak. Are you guys now of the opinion that you should only do arterial, these major arterial reconstructions when a total pancreatectomy is done, so there's no pancreatic anastomosis?
So it's a great question. It's definitely something we consider. If a patient's getting a head resection and needs a hepatic or SMA resection, we always do a total pancreatectomy. However, if the patient has a celiac and it doesn't have pancreatic head involvement, the options are either a subtotal versus a total. There's benefits and disadvantages to both. So obviously doing a subtotal, you can potentially save the pancreatic head. You're no longer going to have a hepaticojejunostomy, which can now colonize the bile duct, and you avoid some infectious issues with ischemia in the biliary tree. The other benefit of saving the head, you could also save the omentum, you know, just based on the gastroepiploics, even taking the stomach. And one of the things we learned is when we do these grafts, you have to cover them with some sort of soft tissue. If you just have a graft sitting there with 60 beats per minute, you know, 24 hours a day, that patient's going to have a pseudoaneurysm or some vascular complication because you're taking away that external pressure that they normally had. So you have to wrap it with something. But by saving the head, now you also have the added risk of obviously a pancreas leak. And we know with a distal, the leak rate's higher. But in general, those leaks tend to be not as severe because they're not associated with a concurrent bile leak like you have with the Whipple, you know, which then contaminates everything. And it could be more of a sterile leak. So the key thing is if you're going to be saving some pancreas, you have to assure that you're somehow mitigating, covering your grafts, and any collections need to be judiciously drained. We keep these patients on long-term antibiotics, bowel rest, TPN. We do a lot of things we normally wouldn't do, like, you know, the typical fast track. This is the slow track. So.
Doctor Truti, usted en su serie menciona que la hemorragia postpancreatectomía es uno de los factores que se asocian a muerte posoperatoria y quizá esto asociada a una fístula pancreática. ¿Usan ustedes algún tipo de estrategia de mitigación como sondas pancreáticas externalizadas o pasirriótide perioperatorio?
I use everything I could get my hands on, you know, so if there's some potential benefit, I use it, you know, so whether there's hard data or not. Because again, the problem, if one of these patients, you've altered their anatomy. So your typical IR bailout options, you know, going to IR and coiling something are usually gone, you know, because they don't have a typical way to get a catheter there. So typically if these patients have a major vascular problem, it could be immediately fatal, or the options are going back to the operating room, which we know is going to be almost likely fatal as well. So the goal is not how you deal with the bleed, is preventing the bleed in the first place. That's the key thing, because a lot of your bailout strategies are no longer going to be effective. So we use a lot of, glue, bioglue, a lot of soft tissue, round ligament flaps, anything we could get our hand on that's vascularized, wrap everything, protect it, keep it away. We do serial scans, aspirate collections, you know, making sure we're tailoring the antibiotics according to the cultures, etc. So.
Gracias, doctor. Doctor Kim, ¿cómo modifica la quimioterapia adyuvante el factor pronóstico de los ganglios linfáticos? Uno espera siempre resecar 15 ganglios y a veces cuando uno da quimioterapia adyuvante, el patólogo te reporta menos de estos 15 ganglios. Entonces, ¿qué impacto tiene la neoadyuvancia en los ganglios como factor pronóstico.
Would you repeat the question about the node numbers?
¿Cómo modifica la quimioterapia en adyuvante el conteo de ganglios linfáticos en la pieza de patología? Usualmente uno espera tener 15 ganglios como un marcador de haber hecho una buena etapificación. ¿Cómo esto es modificado por la quimioterapia en adyuvante?
Yeah, I'm not aware of any studies, and I defer to other speakers as well, of a relationship between the neoadjuvant therapy and the lymph node number harvested. I think we do see some sterilization of the lymph nodes as well if we do have patients who undergo neoadjuvant chemotherapy.
So a lot of that is, did you remove everything, or do you have a good pathology tech who's going to go through, with a lot of detail and find every node? To deal with that, I tend to send the nodal specimen separately, so I skeletonize the right, left, common, proper, all the way to the celiac, and I send that packet, initially first, so they can work on that, and they have to find something. Then I tend to do a more extensive nodal dissection. I take the aortocaval lymph nodes above and below the renal vein, because the nodes aren't in the pancreas; they're surrounding it in that area. So if you send it separately, you tend to get your higher nodal count. And it's not the actual number of nodes, it's knowing that you actually removed all that soft tissue and all that at-risk tissue. If you could see it and you could take a nice photograph and it's all clear, it looks like netter, you've done a pretty good job.
Dr. Helton, there are some groups that suggest that it's useful to do a mesocaval shunt in advance of all the vascular and major resection during Whipple. Do you think this is a worthy effort to do a mesocaval shunt first before doing all the vascular resections and reconstructions?
Well, I don't have any experience in doing that. Now, mind you, we aren't doing combined arterial and venous reconstructions like what Dr. Trudy does. When we have a major vein reconstruction, our clamp time is always less than 20 minutes. And so I don't think it's necessary in those circumstances. But if you anticipate a really long portal vein clamp time, like 45 minutes, there's probably a benefit of doing so. We just have not had to do that when we're doing a venous resection and reconstruction by itself.
Yeah, the vein, in my opinion, that's the number one reason I say no to people. I mean, any artery you could clamp and sew one end to the other. The vein, that's the real challenge, particularly if it's occluded, you have a lot of collaterals. You could get in a lot of trouble really fast that you're not going to be able to get out of quite quick. So these mesocaval shunts have been described. I've probably been counting my hands how many times I've done that. It's typically for more benign type tumors, more neuroendocrine or SPTs and things like that in younger patients where it's strictly just a venous problem and I'm not all that concerned about other tissues.
Ismail, I have another comment and a question for Dr. Trudy, if I might.
Yeah, sure. Go ahead, sir.
Mark, I think that one of the problems in this emerging field in interpreting the outcomes is the fact that many people, particularly in Europe, are doing these big vascular resections on patients with stage 4 disease. If you look at the paper by Philippe Bachelier, which was just published in the Annals, they will do arterial resections in patients with, quote, limited peritoneal disease and with less than 3 liver metastases. Well, that's stage 4 disease. And I personally would never advocate that. I think that when you look at the lousy long-term survival in those things, we can't sort out, is that due to the patients that had metastatic disease, peritoneal disease? And so I think if we're going to learn from this, it has to be done in an extremely standardized manner with a well-defined selection criteria like you guys are using, only to make sense out of the outcomes. That's my comment. My question to you is, what is your opinion about doing an arterial resection in the setting of stage 4 disease?
So the quick answer is never. I would never consider that. A longer answer, which you kind of referred to, the key thing is you have to have strict criteria. And it's not right before the operation. You have to get them adequately staged at diagnosis. And I know something, Scott, that I know your group does and not many people do, and I've incorporated that. Every patient at diagnosis gets a staging laparoscopy with cytology, period. I want to know now. For some reason, people think, oh, well, neoadjuvant, you know, the yield on laparoscopy is so low. Well, the biology hasn't changed. 30% of people have synchronous peritoneal disease. What you've probably done is you've probably had some treatment effect, and now you're understaging these people. So I want to know at the beginning. That could also eliminate a lot of grief from patients who are now thinking they're going to get an operation at some point, and now you find it, and all a big waste of time for them, and then a potentially waste of radiation and other non-therapeutic modalities. I would never consider one of these extensive resections in anyone with any distant disease. Have we ever operated on patients with metastasis? We have. The liver metastasis, we've abandoned. Those patients invariably recur within 6 months to a year. Now, a lot of these European studies, they keep quoting, you know, what's the that's the key thing, is what's our comparator? They keep saying, well, it's better than a bypass. Bypass isn't the comparator anymore. That used to be the comparator. That's why we used to tolerate positive margins. The
Right.
comparator is chemotherapy and chemoradiation, which has about almost a 2-year median survival. So if you're going to subject someone to an extensive operation, the survival better be significantly greater than that. And I think that's what our future comparative outcomes. You know, it's you start time 0 is at diagnosis, and you give them all the therapy, you don't burn any bridges, and then what does adding an operation at the back then offer that patient? That's the big question.
Agree.
Uno de los metaanálisis que citaba el doctor Truti en su plática, el Zucker, publicado en Lancet Oncology en 2016, es un metaanálisis interesante donde estudian pacientes con cáncer de páncreas localmente avanzado que reciben quimioterapia en adyuvante con FOLFIRINOX, y curiosamente solo el 30% de esos pacientes llegan a tener cirugía, o sea, el 70% tienen únicamente quimioterapia y aún así logran sobrevidas cercanas a los 20 meses en estadios localmente avanzados. La razón de este comentario es que una de las críticas más importantes a las series quirúrgicas de procedimientos agresivos, como son las resecciones arteriales, es la falta de un denominador. Es el únicamente enfocarnos en aquellos que llegaron al quirófano y en que realmente no sabemos qué sucede con todo el otro grupo de pacientes que se quedaron en la quimioterapia o que por alguna razón no llegaron a cirugía y que no sabemos en realidad cuáles fueron sus desenlaces. ¿Qué opinan de esto? ¿Realmente el denominador es un factor que genera que tengamos una sobreestimación de los resultados en series esencialmente quirúrgicas?
So that's a great point. The problem with the denominator, who do you include? Every single person? Are you going to include the 91-year-old in a wheelchair on oxygen who has locally advanced disease? Does that person count? They never would ever be considered for surgery. You know, so that's the problem with including everyone. The numerator is obviously it biases things. So what I try to do is look at that numerator and try to find as many patients that look like that numerator, because those are the people that I think are probably going to benefit. So, but yeah, unless you do some sort of a prospective study where you include all patients, which at least conditionally, and they want to undergo an operation and then follow them. I think there was I can't recall a study in the UK that did that. And about, 60% of those patients ultimately underwent resection, which was, a pretty high percentage. And this was, 8 years ago. And they really picked patients who they thought would potentially go to the OR conditionally.
Doctor Kim, algunos centros sugieren al momento de estar haciendo el Whippley y si uno va a hacer una resección vascular, tomar biopsias del tejido alrededor de los vasos para realmente saber si uno va a dejar un margen R0. ¿Esto es una práctica común o usted tiene alguna experiencia al respecto?
Yeah, I don't usually take biopsies. I think it's with this kind of operation, trying to figure out in the operating room, I don't think that's a good approach to have. I think you need to have a very clear plan, step 1, 2, 3, 4, 5. And you need to, at least it's my humble opinion, that we need to have the operation planned out from the very beginning, every millimeter of the operation, really. And I think if you are not able to do everything, offer the patient everything, including portal vein, artery resection, going into the OR and just trying to kind of figure out biopsy here and there, I'm not sure if that's the best approach. If it's a portal vein resection, if I think that the patient, that the vein is involved, I just take a wide margin. I don't send frozen from the vein margins, but what I do send is a separate vein margin for permanent section, because if you don't have a engaged pathologist, if you send some of these specimens down, they go in the formalin, next day they will section them, and then although you know in your during your operation that you actually got R0 resection based on your dissection, the specimen will shrink. Some of the vascular structures will shrink into the tumor, and when they cut it, they'll call it an R1 resection. So I think you know, I know that you know that the French group, you know, sometimes puts a drain into the veins so that they can show that the vein is or artery is truly away from the tumor. But I think it's no, I don't routinely biopsy. If I think that the vein is involved or artery is involved, I would just go and resect. Again, I think Dr. Trudy made this point in the beginning. You have to have a plan based on the type of patients you're operating around. If it's a patient with abutment, I think you can try to push the artery away. But some of these patients have arterial encasement. I don't know if that's trying to push it away, dissecting down to the tumor. I think that goes against the surgical oncology principles. At least that's just my opinion.
Yeah, and again, you know, we see this in testicular cancer. We see our urologists, you know, often call us in. They have, you know, these nodal masses that encase the celiac and SMA. But the complete path response rate for testicular cancer is 90% plus. So they just go in and kind of skeletonize the vessels because they know they're leaving real dead tumor behind. Complete path response rate in pancreas cancer, unfortunately, is 10 to 20% in the best series. It's not 100%. So I don't care what your biopsy is showing you, the 80% likelihood you're leaving, you know, viable tumor behind. And when we do these operations, we don't go in a normal anatomical plane. You know, you're completely outside. You shouldn't be seeing the tumor at all. You know, that's what makes it a little bit more, well, much more complicated, is because you're in non-anatomical planes. The more blood vessels you have involved, you have more points of fixation. So if you have one vessel, now you have 2 points of fixation. You have two vessels, now you have 4 points. Now if you have the vein involved, you have 6 points of fixation. You can't move around and you're kind of stuck, and you have to go through the anatomy in your head. Okay, where do I go first? What do I clamp? What do I revascularize? And in what order? I mean, it's a fun thing to go through your mind when you're going through these, but you have to take that into consideration.
Yeah, and I think if I can add one more thing, we do these complex operations that are well planned, do it for 10, 12 hours. And I think the same attention, careful attention needs to be paid for the pathologic processing. I think it's really important to have an engaged pathologist, and also it's our job as surgeons to, you know, help them understand the operation, but at the same time, you know, send separate specimens so that we do quote unquote protect ourselves. You know, when we know that we got R0, we don't want to be misinterpreted or represented by a pathologist who doesn't understand the operation. I don't know, Mark and Scott, if you have a separate, different way of processing these specimens. You know, we do sometimes ink different aspects, and I do send different margins, especially the vein and artery margins separately, to ensure that we have R0 resection.
Well, I agree in concept, but we, our faculty, we all take the specimen ourselves to the pathologist, orient them, ink everything. We are there to make sure they ink things appropriate, so we really delineate it. We'll just typically mark what we think is the margin with different sutures, you know, in different places. But we're firm believers in the surgeon going over the specimen with the pathologist so they're appropriately oriented. And I agree with your comments on the vein as well.
Yeah, if you don't explain to them, what you've just handed them, they have no concept. They're looking for, okay, where's the SMA margin? I'm like, the SMA is here. Okay, so you clip it before you cut it, so you could go back, as Peter said, they shrink up and those vessels will retract into the tumor. And if you're not there telling them right here, this is my proximal celiac, this is my distal proper hepatic, this is this, I need a ring of this vein cut. So that's the key thing.
So I will pose this question to all the panel. Sometimes it's pretty hard just from the CT scan to know which patients are responding to neoadjuvant chemo. So for each of you, which are the changes on the CT scan that push you to pursue an arterial and a vascular resection?
Well, I will say that, it's well known that once you start down the neoadjuvant chemo pathway, that the changes you see on the CT scan around the vessels are notoriously unrelated to the histopathologic, what you see pathologically. So that's why, as Mark said, it's so important to have other measures. We use also, like they do, PET scan and the CA19-9. We are just making sure there's no progression anyplace else. So if the changes persist, but the CA19-9 curve has gone down and the PET response has improved, then there's a leap of faith that the cancer has been killed and we would operate. So I personally think we need to have something more than just the radiographic imaging, as Mark alluded to. But we know that, at least by CT scan, it's unreliable. Maybe Mark can comment on the MRI PET, because I think they're learning that might be more reliable.
So, I agree everything that Scott stated. We do use a lot of Petamar. So when Petamar first came here, they didn't have a use for it. The radiologist bought this expensive machine and they were trying to figure out indications. I heard about him talking about it in the elevator. So a Petamar, the differences between a Petamar and a PET CT, it has a much higher metabolic sensitivity, about 5-fold, because they use a different detector system. And they combine it with a contrast enhanced MRI done at the same time. So you get really nice anatomical imaging. And we found that 90% plus of tumors prior to therapy, you can identify a nice avid lesion. And that's what we're looking at. I want to find something nice and hot to follow. And then we subsequently treat. And that's the first thing I want to look at on the restaging, is what does that PET show? It gives you not just avidity, but overall, viable tumor volume. It correlates it, with areas near the vessels. So that's really kind of changed my practice. Those patients who can't get a Petamar, have a PET CT elsewhere, we'll just continue with the PET CT, but you need something. The other thing I comment, if you look at NCCN, they made up these arbitrary, measures. So you need a 50% decrease. So if you went from 2,000 to 1,000, that's a patient you're going to take to the operating room. I mean, come on. You need to take it to maximal effect. And if you could get it with first line, great. If not, you switch to see if you could get that last squeeze, because the probability of these patients going on to get any real chemotherapy after these operations, at least in our practice, we haven't been able to get them onto treatment because they're spending months recovering. So that's the key thing. You maximize the response, not just get an initial one.
Thanks. So there are times that we operate on this patient and they may have an isolated recurrence of the liver, small 2-centimeter lesion in the liver. Do you guys support to do any local therapy like ablation, IRE to this type of recurrences, or just do not and keep giving any chemotherapy?
I mean, the whole concept of, oligometastatic, I don't know what that means. It just means how good are you looking, If you just see one lesion, at that point, I think you have to start from scratch. You got to get back to systemic therapy, because it's not that one lesion that's going to take the patient's life. It's the 27 others and the other parts of the liver that are, probably going to progress. Now, if you get them back onto treatment and that's all you have left, then you could now consider local therapies. If they've had a biliary enteric anastomosis, I'm a little hesitant about RFA. that's where I think IRE probably has a benefit, IRE in the liver, because it doesn't cause, real damage to structures. So you could potentially treat a lesion without hitting some of the bile ducts that are in difficult locations.
My experience is anecdotal. I usually, if they recur late, and also they've had systemic therapy, sometimes we discuss it with the medical oncologist to see if they can come off chemotherapy for a bit to see what happens. In the last 2 or 3 years, I've only resected one person who recurred about 2 years later, and he'd been off, and he was initially treated with chemotherapy, off chemo for another 6 months, and the liver lesion hadn't changed. So I offered, and it was in a pretty favorable location, like segment 4B. So it wasn't a morbid operation. So I offered that patient resection. He's still alive, but I think they just have to be. I think again, I think the philosophy is not how we can offer these patients surgery, but how surgery can be put in the context of the patient's entire course. Can it be? But I think the dogma is changing, right? Because how we do things in HPV surgery also has changed as well. Things have become safer, and so I think that's the whole, at least just my own philosophy. Like surgery is one of the main components of this patient's care. So.
We're not in favor of liver-directed therapy for metastatic disease, no matter how long the interval is. I looked at about 10 patients that had been treated as such shortly after I went to Virginia Mason, and 80% of those patients, the single metastatic focus was the tip of the iceberg. Within months of either resecting or ablating those lesions, the patient demonstrated other metastatic disease. Our practice would be to offer them second or third line chemotherapy.
Yeah, and that's what you're probably going to see now. Different phenotypes. Lung mets, I think, are a different thing. Like lung mets for any type of malignancy, for whatever reason, those patients tend to do better, than liver or peritoneal. So, I'd agree, Scott.
Bueno, sin duda este es un tema muy interesante, controvertido, y sin duda tenemos aquí a algunos de las personas más experimentadas al respecto, Dr. Trudy, Dr. Franzen, Dr. Kim, Dr. Helton. Dr. Helton, thanks a lot for being here. Vamos a cerrar la mesa de discusión. Llegamos ya al tiempo. Les agradecemos a todos su participación. We thank all of you for your attendance to our meeting, and we are glad to share this discussion with all of you. Thanks a lot.
Thank you for inviting me.
Thank you.
Yeah, likewise. Thank you.
Really great. Thank you.
Stay safe. Merry Christmas. Happy holidays, everyone.
Thank you.